and is keen to sort of share her knowledge on this. Thank you so much.
Thanks very much. A hard act to follow. So we're going back to basics now, and we're going to look at the dietary strategies in relation to the management of obesity. And this field has changed an awful lot in the past few years, and our thinking around diet and its impact on obesity and how we counsel patients has definitely changed. So I'm going to take a little tour of where I've been in my career so far, where I started from, and what has changed really in the past few years. And there has been quite a bit of change. So as Professor Miras was saying, the population shift in general in relation to BMI has increased over the years. So we're all getting a little bit heavier, and that has resulted in more people heading into the realms of overweight and obesity, which has been reflected in our referrals. So I work in the regional bariatric medicine and surgery service in Galway. So we cover really the whole of the Western Seaboard. So we see people from North Donegal down to Cork, really, at this stage. So our service in earnest started in 2011. Around then, we had about 300 referrals a year for the service. Went up to about 700 in 2019, but then COVID hit and this happened. So we've had a doubling in our referrals from 2019 to 2022. Our referrals have doubled. And we're getting roughly about 50 to 60 referrals every week for people who are living with severe obesity. So at the higher end of the scale, more people are definitely being affected. And as Professor Mears also suggested, the aspects around obesity and the drivers of obesity are really, really complex. It definitely isn't as simple as just how much food you eat and how much you exercise. This is a slide from the Foresight report back in 2007 in the UK. You might have seen it before, but it really does highlight how complex the whole system of obesity is, and really how multiple drivers are impacting the development of obesity in individuals and in our environment. Now, when I started out, this was it: eat less, move more. Just tell people, they just don't know what to do. That was the premise, that tell people what they should eat and how much they should exercise, because knowledge was the problem. And there've been multiple promotion campaigns, multiple education campaigns, but the problem has continued to get worse. So obviously that's not something. But really we need to focus on, really, it's not just knowledge and behavior don't match always. So human behavior flows from three main sources: desire, emotion, and knowledge, as Plato said. And it really is more than just knowledge. And it really does drive home the fact that, you know, like, people who come in to see me in our clinic with severe obesity, they can tell me the amount of calories in every food under the sun. They could write books on nutrition. It's not knowledge that's the problem. There's other things behind that, and there's other drivers that really we need to consider as well. Motivational interviewing then became something. So behavior change training is something that was driven in relation to dietetic training. We were very much involved with the patients and trying to change behavior. Like, the counselling aspect of it became something that was really pushed, and that really does help. But yet we're still left with meal plan, exercise plan, based on the healthy based on the food pyramid, and just, you know, really the degrees of weight loss we were getting weren't very successful. Then we met this guy. So this is Dr. Arya Sharma. He's a professor of obesity management in Alberta in Canada, and he developed something called the Edmonton Obesity Staging System. And this really looked at obesity in a different way. So it's looking beyond BMI to other aspects of the disease. So it's looking at societal factors, looking at the disease process, looking at even things like functional matters to stage obesity and look at the degree of excess weight in a different way. And his group also developed this book called Best Weight. This is downloadable free on their website. And this really changed the way that I thought about obesity management. Now, the Best Weight concept is something that was a light bulb moment for me. So some quotes in the book are: a patient's best weight is whatever weight they achieve while living the healthiest lifestyle they can truly enjoy. That really is the crux of it. There comes a point when a person cannot eat less or exercise more and still like their life. The weight they attain while still liking their life is their best weight, as without the addition of pharmacotherapy or surgery, no further weight loss will be possible. So really, it's looking at it like in terms of, what is feasible for patients. We can push them too far. Anyone can go on a diet. You can go on a diet in the morning and you can lose 3 stone. 6 months later, you're up 4 stone, because the sustainability of many diets is not something that people can sustain for long periods of time. So this best weight concept is something that I think has really changed the way that we look at obesity in terms of its management. And there was a clinical practice guideline developed in Ireland, 2022, I think it was 2022, I think it was released. So this really was based on the Canadian guidelines, and the best weight concept runs through these guidelines. And it's really looking at, what approaches work, what approaches don't work, and what we can do in terms of long-term management. So dietary restriction to promote weight loss works. Every diet works. It works when you're on it. It's when when you stop the diet, the weight comes back. So putting people on restrictive diets really doesn't work, because there's a compensatory mechanism that affects metabolism, promotes calorie intake, and increases the hunger hormones and the drive to eat. And this study actually is really interesting, study by Polidori in 2016. And this was a study that was done on people who were on a placebo trial for canagliflozin. It's an SGLT2 inhibitor. And what that does is it increases glucose urinary excretion. So the patients were losing weight without being directly aware of the deficit. And what this found was that for every kilogram of weight the patients lost, their appetite increased by 100 calories per day. So that really was looking at it in terms of, we always thought that there was energy expenditure adaptations when it came to exercise, and that people naturally reduced their physical activity as they lost weight, and that's why the weight went up. But this really suggests that it's actually the counterback in terms of appetite that is driving that weight regain. And this consensus statement from the American Society of Nutrition looked at this and looked at the evidence behind the energy balance. And what they really looked at, when people go in calorie restriction, what happens is that their appetite increase and their satiety decreases. So really, it's a fight and a losing battle, for want of a better word, really. So it's trying to really find where the middle ground is there and what will work for patients. The other thing that I would have said a lot was that 500 calories a day, just eat 500 calories a day less, 3,500 calories a week, and you'll lose a pound a week. That's not true. Weight loss isn't linear, doesn't account for a weight plateau, and it results in an overestimation of weight loss potential, and it can really result in patients getting disheartened. So it's something that I would suggest we don't say anymore. The other thing we need to consider as well when it comes to weight loss is older adults. And we're finding this more now, is that, as people are living longer, we're having more people in older years coming to our service, even looking for bariatric surgery. And this is a discussion we've had even in relation to bariatric surgery, because we have to be really careful when it comes to older adults. As they lose a significant amount of weight, there's a potential for sarcopenia, frailty, and functional decline with muscle mass loss. So something they really do need to consider. And the FSAI and ESPN have rolled in on this, and they have urged caution when it comes to weight loss and calorie restriction in older adults. But where weight loss is considered appropriate, energy restriction should be at a level to induce slow weight loss to preserve muscle mass as much as possible. And really, weight loss diets of less than 1,000 calories a day should be avoided. Any dietary interventions that we do with these people should be combined with physical activity so that we can preserve as much muscle mass as possible to reduce the associated functional decline. Now, what do we do then when it comes to medical nutrition therapy? There's no one size fits all. Really, it's looking at the patient in front of you and deciding what's going to work for them. A lot of people come in and they know what they want to do, but they just need to be supported with it. As I say, a lot of them are very much experts in nutrition. Some of them you can talk through the pros and cons of really what's going to work for them, or really trying to assess based on what they're doing already. But really, there is no one diet that really is going to fit for everyone. Some clinicians have preferences as regards what they suggest. The low carb seems to be very much to the fore right now, but really when it comes to it, it's all about individualization of treatment. There's a variety of approaches that have been researched and can be considered. Varying calorie restricted patterns with varying micronutrient distribution ranges. Low carb works for a lot of people. Moderate carb tends to work for more people. Mediterranean dietary patterns, vegetarian, some of these I know very little about. Portfolio dietary patterns, low glycemic index, DASH, which are all really roughly around the same. Nordic dietary patterns, partial meal replacements, intermittent fasting is very popular right now. And then more intensive approaches can be considered in those living with pre-diabetes, who need about 5 to 7% weight loss to induce to come out of the pre-diabetes range, and people with type 2 diabetes. So as the direct trial would have shown, between 7 and 15% weight loss is what you're looking at there. And that's really looking at total meal replacements followed by gradual food reintroduction, which is intensive, but it works really well for certain people. So when people come in, what approach is best? Really, they're all roughly the same. And numerous meta-analyses have shown this over the past few years. So looking at low carb, low fat, intermittent fasting, like Mediterranean, they really are showing that when it comes to long-term weight loss maintenance, there is very little difference. So really it's trying to look at what works for the individual patients. So when it comes to take-home messages around this, there's a wide range of acceptable intakes of macronutrients for weight loss. The quality, as a previous speaker said, is equally, if not more important consideration, particularly looking around the consumption of ultra-processed food. So trying to really improve the quality of the diet is really important, particularly when it comes to cardiovascular outcomes, because that's something we really need to consider as well. We need to think about individualized medical nutrition therapy where it's available, but I know that services are really patchy. And there's a wide variety of eating approaches that may be considered. And incorporating the best weight concept to identify what's sustainable is really, really important. So looking at the patient in front of you and working with them to look at what they can do long term. Because doing it for 2 months, 3 months, 6 months, it's like any treatment. It's like when we talk about the pharmacotherapy, when you stop the treatment, the weight comes back. Same with diet. When you stop the treatment, whatever treatment that is, the weight will come back. Looking at then what's available around the country. So the model of care for the management of overweight and obesity was published in recent years, and this looked at what services were required for the management of obesity in the varying settings. So looking at primary care, the specialist ambulatory care hubs, then up to level 3 and 4, which is looking at the specialist regional services. But there are some services available now in the ambulatory care hubs that are really useful to know about. So this Best Health Weight Management Programme was piloted a couple of years ago, and this is a behavioural intervention that's available in Donegal right now, but I think there's plans to roll it out in Sligo Leitrim next year. And this is a dietitian-led behavioural intervention programme that's run out of the specialist ambulatory care hubs. And this is available for adults with a BMI of over 30 with 2 obesity-related comorbidities. So things like type 2 diabetes, hypertension, hyperlipidemia, sleep apnea, PCOS, or osteoarthritis. And this is something that focuses on, you're focusing on diet, exercise, sleep, and stress. So they get a 60-minute face-to-face consultation with a dietitian, followed by 14 90-minute behavioural group support sessions over a 12-month period. And this is something that is being rolled out right now. There's also a program available for people who have a diagnosis of pre-diabetes. Again, a similar sort of program in terms of the intervention, focusing very much more on the exercise, the eating for health, and then looking at behavioral changes to try and reduce their HbA1c. And this is for people who have a diagnosis of pre-diabetes. These are run virtually, so they do suit a lot of people. I was involved in the pilot for the diabetes prevention program, and the uptake was actually really good. Retention was really good. So very positive results from both of these programs. Then when it comes to bariatric service, we have multiple interventions that we run there. So we run a behavioural intervention as well. It's an 8-week behavioural intervention in collaboration with CRE. We also do a sleeve gastrectomy, and we have run a milk-based meal replacement program for high-risk patients as well, an outpatient program. So these are the interventions that we do. I just want to mention bias, because bias is something that's really important, and medical professionals actually, it's been shown that medical professionals are really the worst when it comes to the inherent weight bias, and it's something that really is damaging for patients. So we had a lady actually in clinic during the week. She came in for a surgical assessment, and our nurse said, "It's not your fault. You're fighting biology. It's not your fault." And she just burst into tears. And "You're the first medical person who has ever said that to me. Usually I go out of a clinic, I've got osteoarthritis, I've got all these multiple health problems. Every doctor I go into, lose weight, lose weight, lose weight, eat less, move more." And some of the stuff she told me that doctors have said to her, and other healthcare professionals, not just doctors, dietitians are sometimes the worst. It was just shocking. And she just said, "I always go out feeling a sense of shame, and it's the first time I don't feel that." So it's something we really need to check ourselves on. And bias and discrimination really is important. We need to kind of check ourselves on that. It is improving. I will say that it definitely is improving. And I think there's a better understanding of obesity in terms of its drivers. And I think that has helped immensely. So we need to be realistic as well when it comes to what diet and exercise can achieve. You're not going to get the effects you get from drugs, which is like 5 to 20% weight loss, or surgery, which is up to 40% weight loss. You're really looking at the lower end. So between 2 and 10% weight loss in terms of nutritional intervention is about as much as you're going to achieve. That might be satisfactory for some individuals, and it will definitely improve their metabolic outcomes, but for some it just won't be enough. So it's really something that can be, other things can be added on top of that. I do think that improving the quality of diets is really important in terms of cardiovascular outcomes and weight as well, but it is in addition to other things for people at the severe end of the scale. And this is what the map looks like when it's not organised. It's a mishmash. So really, it's something that that we need to realise that it's very, very complex. It's complicated, and it's something that we all need to work together to try and get a handle on. So thank you for that.
So do we have any questions? Thank you very much for that. It was really interesting. I really like the concept of best weight because, again, just thinking back to some of my own family members, there's that huge guilt that people have and probably are given. And the idea that you have a best weight is a very positive concept. Are there any questions from the floor? Yes, they've got if the mic could make its way around here to the lady in the Aaron type jumper.
Thanks, that was really interesting. Just in regards to diet, there's quite a few options you had there on the board. What is the optimum diet for health, and what should you be advising people in regards to what it is they should be eating?
So really, like there is no optimum. It's improving the quality of diet in general, and within that, then it again, I think reducing the intake of ultra processed food is the first part of that. So going back to basics as regards, you know, unprocessed food is the basis of it. And then within that, then it's whatever the patient wants to do. Again, a lot of people who come to see me at the severe end of the scale, like they know every diet. They've done every diet. It's like they've done multiple diets and they would have their own idea of what has worked for them in the past and what hasn't. So I would always look at that, like what's worked, what kind of worked, what do you think might be feasible in the longer term. And I think it's within the quality, once the quality is improved, the nitty gritty and the overall picture really will be driven by what's feasible for the person in front of you.
Thank you. Any other question from the floor? We've one back there at the back. I think there's a gentleman at the side who might walk it back, but it looks like it's making its way like back again.
Like this? Okay. So my question is very quick. I know there is no one general answer, but you mentioned sleep, the importance of sleeping. What would you say? Because I think it's nobody thinks about that, or at least most. Like my uncle has problem with obesity, and he sleeps very badly, at least from my point of view. So I would like to know a little more about that. What should be an optimal sleep, or even knowing that it will change between people, of course, but yeah.
Yeah, so obviously it does change between people, but getting sleep hygiene right is really important. So like a lot of people that I would see living with obesity, they would have very poor sleep hygiene in terms of staying up late at night, getting up late in the day then, and then tired during the day. So they're snacking on high sugar, like high sugar food and drink to compensate to try and give them that buzz. Really, particularly sugary drinks. They would tend to drink like energy drinks and caffeinated drinks to try and keep awake then. That's all driven as well into the whole like undiagnosed sleep apnea, I think is a big part of that as well. And a lot of people are going around with undiagnosed sleep apnea. And I think that also impacts greatly on sleep. So sleep hygiene is really, really important when it comes to the overall picture of managing weight. And it's something we often don't think about.
Thank you. Are there any further questions from the floor? No. Thank you so much.